And so I quote I include a quote here from Fixon et al. From 2010 that sort of highlights the importance of implementation science. And it states that the delivery system matters. So Fixon et al. Indicated that the use of effective interventions without effective implementation strategies is like a serum without a syringe. The cure is available, but the delivery system is not. And so I'll start off with a little bit of background with regards to implementation science terminology. This is taken from a paper by Kuran 2020. He uses it as a teaching tool. And basically, the intervention, practice, or innovation is simply referred to as the thing. Effectiveness research looks at whether the thing works. So that's the intervention, the practice, the evidence-based, the tool. Implementation research looks at how best to help people and places do the thing. Implementation strategies are the stuff we do to try to help people and places do the thing. And the main implementation outcomes are how much and how well they do the thing. So hopefully this provides some background as I start talking about some of the studies that I've done. And so the key goals of implementation science are typically to understand the determinants being the barriers and facilitators of the adoption of the evidence-based practice or tool or intervention, to develop and test strategies to help implement that evidence-based practice, and to ensure, ensure interventions are effective, sustainable, and scalable in real-life context through implementation trials. So over 117 models, frameworks, and theories exist for specific aspects of implementation science, including the identification of determinants, again, those are barriers and facilitators, implementation strategies, and implementation outcomes. The IRLM, the CFIR 2.0, and the behavior change wheel, so IRLM being the implementation research logic model, CFIR being the consolidated framework of implementation research 2.0. Three of these models and frameworks in implementation science and the ones that I've used so far in my research. And I'll talk a little bit about these models over the next few slides. So the IRLM is conceptual, meaning it describes or guides the process of translating research into practice. It was developed in 2020 by J.D. Smith, who is an associate professor at the Department of Population Health Sciences here. And he's also my primary mentor for my K grant. The IRLM has been cited over 466 times per PubMed and is required in multiple FOAs from NIH, AHRQ, and CDC. So the IRLM, and that's what it looks like, at least the bare bones, the template, serves to justify how determinants, strategies, and outcomes are selected and tested in relation to one another. So once determinants of the implementation of an evidence-based practice or thing being implemented are identified, and those can be identified at various levels, and that's those little boxes within the larger box, implementation strategies are then selected to address these determinants. And these implementation strategies work through mechanisms of action to impact implementation outcomes, which are the direct proximal impacts of the strategy, which then relate to the clinical outcomes of the evidence-based practice. So the CFIR 2.0 is an updated version of the original CFIR published in 2009. It is a framework used in implementation science that provides factors believed or found to influence implementation outcomes. So again, the determinants or barriers and facilitators. It consists of 5 domains. So determinants may be identified at the outer setting, inner setting, and at the individual level with regards to the implementation process and innovation. And these consist of various constructs. And finally, the behavior change wheel is an evidence-based model used in implementation science that seeks to capture the factors that affect behaviors and the different types of interventions that can be used to change behaviors. It is the synthesis of 19 prior models of behavior change. And so implementation science is characterized by a variety of research designs and methodological approaches, partnerships with key stakeholder groups, and the development and testing of ways to effectively and efficiently integrate evidence-based practice into everyday routine health settings. And so I have listed a number of the methods that are typically used. These are methods that I've also used in my research. Economic evaluation is not a typical method used as part of implementation science per se, but it's often included in grant proposals, implementation science grant proposals, as a way to show the value and the cost of the intervention being implemented. Okay, so now I'll move on to some studies that I've done in which I've applied implementation science to vision health services research. So in terms of my lab, we employ primarily the use of implementation science and its associated methodologies to promote the adoption and integration of evidence-based practices and interventions into routine healthcare to improve vision health outcomes. Current areas of focus include improving the implementation of evidence-based vision screening and referrals to specialist care to enhance the detection of vision disorders, as well as adherence to referrals and follow-up as it relates to amblyopia, glaucoma, and myopia. So a primary focus in starting my faculty appointment in 2023 here at the Moran has focused on preventing amblyopia in children 3 to 5 years through vision screenings and appropriate referrals. And I know I'm preaching to the choir here, but I have a few slides on what amblyopia is. It's blurred vision in an otherwise structurally normal eye caused by abnormal visual development in early childhood. It impacts about 4% of preschool-age children and is the leading cause of unilateral vision loss. 1 in 5 children at risk of developing amblyopia due to amblyopia risk factors such as anisometropia, strabismus, cataracts, and ptosis. So permanent vision loss can result from amblyopia after the age of 8, which marks the end of the critical period of visual development. And this vision loss may result in reading and learning difficulties and psychosocial impacts. Treatment of amblyopia is dependent on the cause, but it may be as simple and cost-effective as patching of the eye, the good eye, in order to force the brain to process visual input in the blurred eye, as well as prescription glasses. Effectiveness of treatment weakens after the age of 5, therefore early detection and treatment is critical. So American Academy of Pediatrics Bright Futures recommendations recommends vision screening to include a visual acuity measurement or ocular risk assessment throughout childhood. And these recommendations are endorsed by various eye care groups. In terms of vision care services, we're talking about comprehensive eye exams by optometrists or ophthalmologists, and vision screening, which may occur, is supposed to occur in well-child checks, often occurs in schools and in community settings by volunteer groups. So how is vision care paid for in the US? The Affordable Care Act mandates health plans with some exceptions to cover 10 essential health benefits, which include pediatric vision care. And for most states, 42 to be exact, cover annual eye exams and prescription glasses once per year through Medicaid. In Utah, pediatric vision care is covered through Medicaid for children 5 to 18, and prescription glasses are provided once every 12 months. And so in terms of just understanding how well screening is occurring in primary care, so as part of well-child visits here, we have found that in spite of guidelines for screening and the existence of coverage for the cost of care, only 31% of children get vision screening in primary care as part of their well-child visits, even though 92% of them get well-child visits. Data on national rates of referral and follow-up are limited. However, there are 2 smaller studies. One from Ohio shows low rates of referral. So even if a child is determined with abnormal vision, only 26% were referred by PCPs to eye care providers. And then in Florida, we found that the rate of follow-up was as low as 39%. And so the first step has been for me in my lab is to understand what the determinants are. So what are the barriers and facilitators associated with poor vision outcomes in children? Several studies led by myself and other researchers have pointed to several determinants that are associated either directly or indirectly with access to vision care. And this schematic on the screen right now is based on an adapted version of a widely used health services research model called the Anderson's Behavioral Model of Health Services Use. And so you'll find that determinants may occur at the system level, provider, patient, or family. And so I'll talk about, start with two studies that I've conducted to understand what type of determinants or barriers and facilitators occur for children from health disparity populations. So this first study used data from the National Survey of Children's Health for the years 2018 to 2019 and included 49,000 children aged 3 to 17. And the goal was to investigate whether immigrant generation is associated with caregiver-reported receipt of vision testing. And so I have the two questions for the national survey for those years that were focused on vision in that box on your bottom right side of the screen. And so this figure shows the percentage of US children 3 to 17 in the cohort with each outcome. Regardless of the type of vision test received, the lowest proportion of children getting vision testing were those from first, followed by second and third generation households. We did a regression analysis, and after controlling for social and demographic factors, we found that children from first generation households, which is defined as the child and all parents born outside of the US, and second generation households defined as the child born in the US and one parent born outside the US, were less likely to get vision testing compared to children born in third generation households, which is defined as all parents born in the US. We did a subgroup analysis of Hispanic families and found that after controlling for social and demographic factors and excluding children without health coverage over the previous 12 months, children from second generation households had an adjusted odds of any vision testing of 0.73 compared to children from third generation households. And so children from immigrant households show significant disparities in accessing vision care, even with health insurance, and especially for children from Hispanic households. And here, vision care, if you saw the questions on a few slides before, could be it could be anything. It could be an eye exam by an optometrist and ophthalmologist. It could be a vision screening test. Any of those meets that criteria. So future studies are needed to understand the challenges faced by new immigrants in utilizing vision care, and this would be best obtained through qualitative studies. A second study that I published late last year aimed to determine the rate of vision screening for US children 3 to 5 years of age with commercial insurance and compared rates amongst those living in rural versus urban areas. And we use CPT billings from the Meritive Market Scan Commercial Claims Database for the years 2011 to 2020. This database contains demographic and medical claims data from employers, health plans, government, and public organizations for more than 273 million US individuals. And so our exposure that we were interested in was the child's residential location in either rural or urban area defined by the US Census Bureau. And secondary exposures were sex, age, type of commercial insurance plan, and US geographical region to being Northeast, Southwest, or Midwest. Our primary outcome we were interested in was the proportion of children that had a vision screening test indicated by a claim submitted by an individual other than an eye care professional, and this is because we were focused on vision screening. And this could be a CPT code, any of 3 CPT codes for a visual acuity test or an instrument-based test. So this graph shows the percentage of US children 3 to 5 with a claim for a visual acuity or instrument-based test by rural or urban residents. A larger proportion of children, that's 72%, received a visual acuity test compared to an instrument-based test, which was 28%. And a larger proportion of children in rural areas received a visual acuity test compared to 71% in urban areas. In terms of our regression analysis, we found that children living in rural areas had a lower adjusted incident rate of vision testing compared to children living in urban areas. Children living in the Midwest, Northeast, or West had a lower adjusted incident rate of vision testing compared to children living in the South. And children with comprehensive insurance had a low adjusted incident rate of vision screening compared to children with PPO insurance. And so even amongst children with commercial insurance, 71% did not receive recommended vision screening. And geographic location and the type of commercial insurance seems to matter. So again, a deeper understanding as to what could be going on, what these disparities mean, what their causes are, is needed to design targeted interventions. And so my next step has been, well, that was on the national level. How about Utah? Are we seeing similar disparities here? So we're in the process of conducting a chart review of over 1,000 children using EHR charts. The objective of the study was to describe adherence to screening recommendations in one of the largest health systems in Utah. In terms of our exposures, we're interested in race, ethnicity, sex, language spoken, insurance, and screening tool. Outcomes were vision screening, abnormal vision screening, referral to an eye care professional, and we did multivariable logistic regression models. So in terms of our descriptive data, this graph shows that 60% of children who got a well-child visit also received a vision screening test, and 13% of children with a well-child visit had an abnormal vision screening. Or another way to look at it is 21% of those screened had an abnormal vision screening test. And again, this is important because the guidelines indicate that all children 3 to 5 need to get a vision screening as part of their well-child test. This graph shows that 79% of children with an abnormal screening test were referred, and 21% adhered to the referral to an eye care professional. In terms of our regression models, we found that, so chart A is the outcome vision screening, B, abnormal vision screening, and 3, referral to an eye care professional. So with regards to chart A, we found that children that were 3 and 4 years of age were less likely to get a vision screening compared to children age 5. And children in clinic B, so this was across 3 pediatric primary care clinics, and children in clinic B were less likely to get a vision screening compared to children in clinic C. With regards to the outcome abnormal vision screening, children who are Hispanic, non-Hispanic, Black, or other multiracial were 3 to 5 times more likely to have an abnormal vision screening test compared to non-Hispanic white children. And then children in clinic A had a lower odds of having abnormal vision screening compared to children in clinic C. And finally, with regards to chart C, children who are Hispanic, non-Hispanic, Black, and other were about 5 to 8 times more likely to get a referral to an eye care professional compared to non-Hispanic white children, and children in clinic A were less likely to get a referral to an eye care professional compared to children in clinic C. And so for preschoolers in 3 pediatric primary care clinics at the University of Utah Health System, getting routine well-child visits, disparities do exist related to social determinants, and as well as appropriate referrals. There's significant variation as well with regards to how clinics are screening and referring children with vision impairment. And clinical level determinants impact the adoption and reach of vision screening guidelines. And so this basically points us to saying that something needs to be done. We need some kind of intervention to ensure that evidence-based vision screening is being done appropriately. So we're in the process of conducting a qualitative study. So we've done all these quantitative studies. We're like, okay, we really need to understand why these things are happening. So we're doing a qualitative study to get a better understanding of the determinants, especially at the clinic level, and to identify implementation strategies that could be used to address challenges in care. So we're doing surveys and semi-structured interviews. We aim to interview up to 24 pediatricians and medical assistants in primary clinics within the University of Utah Health System. Exposures we're interested in are race, ethnicity, sex, language spoken, insurance, and the screening tool used. Outcomes are determinants, strategies, perspectives on clinical decision support, and we're analyzing our qualitative data using rapid turnaround methods and our surveys using multivariate regression models. Interviews were designed across 7 domains on the screen right now, and the content was approved by a pediatrician at the University of Utah Health. So far we have 39 responses to our surveys and 7 completed interviews and 3 interviews that are pending. The interviewees were pediatricians, so 5 were pediatricians, 1 was a medical assistant. Most respondents saw more than 20 children per week for well-child visits, and the others saw at most 10 per week. Most respondents use a Welch-Allen spot vision screener and or a visual acuity chart for vision screening. And the following clinics were represented. So I'm not going to go through all of these, but these are some preliminary results from the 7 people that we've spoken to so far. So in terms of vision screening procedures, it does seem that most children over 6 months are screened, except those already seen by an ophthalmologist or those wearing glasses. VA charts, Snellen charts, spot vision screeners are typically used for visual acuity and to measure the refractive state. In terms of barriers to screening, they indicated that the lack of cooperation of young children was a barrier. Also, fallibility of the interpretation of results and their inability to understand results of screening tests. In terms of strategies to address screening, they felt that clinical decision support could be helpful for knowing when to screen, what tests to perform, and how to document results. They indicated that CDS should be simple, easily accessible, and auto-populate into after-visit summaries. In terms of barriers to referrals, they indicated that they were unable to express the importance of following through with referrals because they did not understand the vision screening results, and that families often lacked resources to follow up. And so the next step has been to determine what type of implementation strategies are appropriate for improving the reach of vision screening in primary care, as well as appropriate referrals. And so existing evidence shows that clinical decision support is effective in addressing determinants at the level of the clinical healthcare system. These are ideal because the Centers of Medicaid and Medicare require that all EHR system make available CDS components, which include alerts and preventive care reminders within the system, and then it's up to the clinic to decide which ones to put on and to design it the way they want. So actionable reminders coupled with referral orders have been effective in a wide range of preventive care programs, including cancer screening and immunizations. Dr. Delfio, who's my co-mentor for my K-grant, and other colleagues at the University of Utah developed a multi-component CDS intervention for lung cancer screening, which included clinic-facing preventive care reminders, shared decision-making with relevant info displays, one-click ordering, and automated documentation, which led to a 5 times increased likelihood of screening. Dr. Stagg, who's here as well, has also designed a prototype CDS to improve decision-making regarding the appropriate timing for follow-up visual field testing for patients with glaucoma using user-centered design and is currently in the process of refining and testing. And so, yeah, this has been clinical decision support seems to be a good way to go as far as our question. And there's been a lot of studies right here at the University of Utah that have used it with success. In terms of addressing patient-level determinants, digital health strategies such as text messaging or chatbot and patient navigators have been shown effective. This is particularly useful given the near universal access to cell phones, even in low-income households. Educational videos and health navigators in particular have been shown effective in improving adherence to health appointments by providing system-based solutions and individual-level motivational and educational practices for patients with chronic disease. And again, these are studies that have been done right here at the University of Utah that have shown the effectiveness of using text messaging interventions. So in terms of my goals for the next 5 years, I have 3 studies in mind. So I have applied for a K-grant through the Agency for Health Research and Quality to improve the implementation of evidence-based policy recommendations for screening in pediatric primary care. So this was scored last fall and I resubmitted in March. So keeping my fingers crossed that it is successful. My second study is preventing diagnostic delays in amblyopia with patient-centered digital health interventions. So this would be the text messaging solution to address patient-level determinants. And then a third study, which is a global health study, is implementation of school-based screening for children in Kumasi, Ghana. In terms of the specific aims, you've seen the slide before. It follows the implementation science key goals. So specific aim 1 will understand the determinants, 2 will develop and test strategies, and 3 will make sure the interventions are effective in real life context through an implementation trial. Now this is very busy and I don't intend to go through every piece of it, but this is what an implementation research logic model looks like once you've gone through the process of identifying determinants, implementation strategies, the mechanisms of action, and the outcomes. And so this is the initial IRLM that I've developed for my AHRQ project. In terms of the methods, so the clinic level study, which is the ARC grant, patient level study, which is the RPB grant, will use semi-structured interviews. In case of the clinic level study, also workflow analysis, and these will be analyzed using rapid qualitative methods. We're making use of the CFIR framework to develop interview guides and for coding, as well as the behavior change wheel. The interventions will be developed and evaluating using PDSA cycles. So planning will involve developing an understanding of the behavior, identifying intervention options or implementation strategies, as well as developing culturally adapted content. And so for the second study, this will include decisions on the frequency and duration of text messaging and order of deployment. So do will involve usability testing, which includes thinking aloud, structured open and ended, closed-ended, open and closed-ended questions, and formative evaluations with surveys. The study phase is where results from the usability assessment and the formative evaluation will be synthesized and additional feedback obtained. So just to step back briefly, so do usability testing is, okay, so we've created this prototype device. Let's get input from the users to understand what they think of it, how it could be improved. And then the study phase will use those results to refine the tool and get additional feedback. And then ACT includes the stages or cycles are repeated until no more refinements are needed. And to address clinical level determinants, we propose the clinical decision support tool. Again, I won't go through this whole table, but the clinical decision support tool will consist of 4 different types of clinical decision support, including preventive care alerts, workflow support, relevant info displays, and documentation aids. And these will each address barriers or determinants that we have identified so far from the literature, such as competing priorities in the workflow, knowledge and access to recommendations, and self-efficacy. And in terms of the text messaging tool to address patient-level determinants, we propose an adapted bi-directional text messaging in English and Spanish that promotes single-touch responses, refers to the patient by name, and is identified as coming from the patient's specific clinic. So in terms of what we have in mind, but again, this will be refined by the users that we work with. It will look like that on the left. So it will include culturally adapted short educational video on the importance of completing referrals. It will also include a proactive phone call from a bilingual health navigator for non-responders to provide motivation, practical advice, and connections to services to address patient hesitancy and access barriers. And in terms of the timing, this is what we propose. So the text messaging will occur over 4 months. So 7 days after referral, they will receive an initial text and video. That's the caregivers. If there's no response after day 21, we'll also send the last message at the bottom. So having a health navigator call them, and they do have the option to opt out of that. And then we continue sending messages about health navigator calls over month 2, 3, and 4. And then specific aim 3 will be to pilot the intervention. Since this is a pilot, we're considering a pre-post single-arm pilot trial over 12 months. Our population will be clinic staff and caregivers. The outcomes we're interested in: acceptability, reach, feasibility, and patient satisfaction. And we will get those data pieces through surveys, interviews, through the EHR and other study data. And so I'll spend the last couple minutes just quickly going through applications of implementation science to a global ophthalmology project. A little bit of background about Ghana: population of 31 million, 16 administrative regions. It's easy to get access to children in the sense that both elementary and junior high schools are usually located in the same setting, so from grades 1 through 9. Some studies have shown uncorrected refractive errors impact up to 45% of school children, and there's currently no national requirements for vision testing. Vision screening currently in Ghana is done by private clinics. or the government through some district and regional hospitals. Humanitarian groups, a number of nonprofits in Ghana do vision screenings. Optometry schools will occasionally give it, but like I said, there is no national guideline with regards to, so there's no standardization in how this needs to be done, how frequently it should be occurring. And so we've done phase 1 of this study where we screened all children from 1st through 9th grade in 2 schools in Kumasi, a private school and a public school. We did visual acuity tests, autorefraction, external exam, and pinhole test. Referrals were done in line with the APOS criteria because, again, there's no standard requirements as to how vision screening needs to be done in Ghana. We are interested in socio-demographic factors because we want to see how that impacts access to screening, vision screening outcomes, and referrals. And so we will do some descriptive statistics and some regression modeling. These are the APOS guidelines that we are going to apply to the instrument-based version. So we do have a spot vision screener that's being used as part of the screening. In terms of preliminary results, at the public school, a total of 42% of the children enrolled were consented to participate in the study, of which 91% consented, and of which 91% of those consented were screened, and 22% of those screened were subsequently referred off-site to an eye clinic for a comprehensive eye exam by an eye care professional. In a private school, 72% of children enrolled were consented to participate, of which all of them were screened, and 37% of them were referred to an eye clinic. Reasons for referral, 79% were referred for ocular pathologies. The most common, and I hesitate to call this a pathology, but the most common pathology was cup disc ratio of over 0.5. I want to believe that that's physiological considering how young the children are, but my collaborators on the other side wanted us to explore that further, and I agree that that's worth doing. So in June, we're going back to the schools to determine how well they completed the referral eye exams, and to understand how social determinants may have impacted the access to these eye exams. And so what we hope to do if we get the funding is then to develop and evaluate a modified screening program. So based on what we're seeing so far, a number of children are not going through with their follow-up piece. So we're thinking that perhaps an on-site comprehensive eye exam, perhaps through a mobile van, might be the best approach to ensure that children don't fall through the gaps. But we'll have to go through the full process, talk with our collaborators, our stakeholders, and identify what they think is best and follow suit with that. And if we're able to do this, we'll also have a host of data from school children in Ghana that we can do further studies with. And so I won't go through this because I've pretty much, it's similar format, focus groups, semi-structured interviews will be done at specific aim 1, specific aim 2. We will pilot the intervention, which we think should be the on-site eye exams through a mobile van. We'll look at a number of outcomes, reach, acceptability, and others. And yeah, that ends my talk. This is my mentorship and advisory team, consisting of J.D. Smith from Population Health Sciences, Dr. Brian Stagg is here, and Mariel Young from the Moran, Carol Stippelman from Department of Pediatrics, Heather Keenan, also from Department of Pediatrics, Melissa Watt, a qualitative expert at Population Health Sciences, Dr. Guilherme Delfio, who's an informaticist, and my advisors at Intermountain Health, Dr. Tim Duffy and Dr. Neil Davis. Other acknowledgements, the CCET team at CTSI who are doing my interviews for me, statisticians, medical students, and then all my collaborators on the other side in Ghana.